Continue with microbiology of the urogenital system. حكينا اليوم الصبح شوي عن الepidemiology. What signs and symptoms we expect in patients with a genital infection or an STD. We talked about the risk factors. So we already can see there's an overlap between STDs in terms of signs and symptoms. So the diagnosis might not always be so simple. And we'll see, if we have time, we can see some clinical cases regarding STDs. So we said regarding the epidemiology, maybe we did not mention, but you can see that over the past 10 years or more, there has been an increase in most STDs. Okay, so the estimated number of new cases in millions is rising. Maybe because of relaxed sexual behavior, given the ability to treat those STDs with antibiotics, people started being less careful. So there's a resurgence of many STDs. Okay, and we said there's a variation between, there's a gender variation and a regional variation in STDs, right? We talked that in our area, maybe the prevalence is not as high as other places. And then we started talking about bacterial vaginosis, how it's related to abnormal flora. There is discharge, maybe itching. We expect to find clue cells when we look under the microscope, and you treat them with metronidazole. Some of them revert back to the normal flora on their own, and some will experience recurrences. And we talked about trichomoniasis caused by a protozoa, and how it's one of the common non-bacterial STDs. It also can present with an itch, discharge, dyspareunia, dysuria. And if we look under the microscope, we see the protozoa swimming around. Then we talked about syphilis caused by Treponema pallidum. Now it can be congenital syphilis. The transmission mainly is through sexual contact and not through inanimate objects. We talked about the stages: primary with a chancre, secondary with the maculopapular and more systemic manifestations of treponema in the blood, and then tertiary syphilis with which affects the CNS and the heart. We talked about the diagnosis with dark field microscopy of the swab maybe, or we can look for non-treponemals or screening tests like VDRL and RPR, and we look for specific treponemal tests where we look for antibodies against treponemal antigens, and you can treat that. You can treat syphilis. Penicillin is quite effective. Penicillin G is quite effective in curing syphilis. And now we move on to gonorrhea. Okay, so gonorrhea, there's a rhea part, like rhinorrhea, where there's secretion from the nose or diarrhea. We have gonorrhea, and that involves urethral secretion. So we expect to find discharge. واسمه بالعربي gonorrhea ايش هو؟ سيلان. Yes, so there is discharge with gonorrhea. And in the mucous membranes of the urethra or rectum or cervix or even the conjunctiva, so in the eye, gonorrhea can affect the eye as well, and the pharynx. So all of this epithelium can be infected by Neisseria gonorrhea. We have seen the sister of this bacterium in another lecture, where another Neisseria in meningitis. We talked about the gram-negative diplococci, Neisseria meningitis. And we said that it can be found in healthy individual. It can colonize the nasopharynx of healthy individuals with Neisseria meningitis. But with Neisseria gonorrhoeae, wherever you find it in culture, then it is always considered significant, which means it's not part of the normal flora, like the other Neisseria. And also, similar to the other Neisseria, it grows on chocolate agar. It's a fastidious organism, which means it needs specific nutritional requirements. And this helps in the diagnosis because it can only grow on the chocolate agar. And you look and you see the diplococci, gram-negative. That alone allows for a presumptive identification of Neisseria gonorrhoeae. And epidemiologically, it's the second commonest STI following bacterial STI, following chlamydia. And there's a concern with gonorrhea because there's a growing prevalence of antimicrobial resistance. So patients are presenting with gonorrhea that is resistant to gonorrheal strains that are resistant to several antibiotics, and that is a major public health concern. So how does gonorrhea cause the disease? Here we can see the diplococci attaching to the urogenital epithelium with its villi, and then of course it will affect the microbiota, as we said, so it will compete with them for nutrition and so on, and change the whole environment of the vagina. They can also, after colonization of the epithelium, they can transcytose, which means they go deeper and they interact with immune cells, such as macrophages and dendritic cells, and even with epithelial cells. All of those cells will have pattern recognition receptors that will recognize the bacteria. It starts to send cytokines and chemokines, and what do those do? They draw in neutrophils, and neutrophils will come to the site of infection, and the diplococci, gonorrhea, can go intracellular in those cells, and those cells can go outside into the vagina and be excreted in the form of purulent exudate. So the pus or the discharge that comes out from a person infected with gonorrhea, we expect it to contain those white blood cells with the diplococci inside them. Okay? So, gonorrhea, أو السيلان, it is mostly, if it happens in men, virtually all of those infected will have acute symptoms, which involve the urethral discharge we see here, along with dysuria. While in significant proportion of women, the infection is asymptomatic. So there is not always vaginal discharge, and if there is, maybe the woman will not notice this discharge. So Neisseria gonorrhoeae can cause several diseases related to each other. So we have gonorrhea, the genital tract infection we're talking about, and it has the purulent discharge, and that can happen depending on the site where the pathogen gonorrhea has infected. We said it can infect even the oropharynx, it can infect the conjunctiva, can infect the genital tract, of course. And because it goes often unnoticed in females, it can progress to disseminated infection. Remember, with Neisseria meningitis, after it colonizes the nasopharynx, it can go into the bloodstream and cause disseminated infection and cause meningitis. Here, with gonorrhea, also, it can cause bacteremia, and then can go to the skin or joints, giving the pustular rash related to Neisseria, and sometimes can affect the joints, causing suppurative arthritis. And in some cases, it can ascend, similar to how urinary tract infections in the bladder, cystitis, can ascend up to the kidneys and cause pyelonephritis. infections of the vagina and urethra can ascend upwards where? Into the cervix, and from there can spread where? Into the uterus and even the fallopian tubes and in other structures of the pelvis, causing something called pelvic inflammatory disease, which we will talk about, or salpingitis, where the fallopian tubes are inflamed, or endometritis, where the lining of the uterus is inflamed. Also can cause abscesses in the ovaries. Okay? So, how can we diagnose gonorrhea? Of course, we will use swabs from the exudates. So this discharge we need to examine. We can do swabs from the cervix also. So the clinician will take a swab from the cervix and put it for the microbiology. This is from the cervix. Take another swab from the urethra. This is from the urethra. Take from the throat, from the places where you expect the pathogen to be, and then you send to the microbiology lab to examine those. And as we said, microscopy and culture can sometimes help in a presumptive identification, and they're very quick. You do a gram stain, you see the gram-negative diplococci, and you do a culture, and it only grows on chocolate agar from genital discharge, then you can assume, okay, this is gonorrheal infection. But now the screening test of choice depends, as in many other STDs, as we saw, it is nucleic acid amplification tests. And when you treat, always remember to treat the sexual partners. As for treatment, ceftriaxone works well with Neisseria, because if you remember also in cases of suspected bacterial meningitis, part of the empiric therapy is also ceftriaxone. Okay, so this is gonorrhea, and we move on to another infection of the genital tract, and that is chlamydia. chlamydia بالعربي اسمها المتدثرة. ليش سموها المتدثرة؟ سؤال كويس. If you look here, the pathogen goes intracellularly, right? So you can see here the elementary body goes into the cell and then hides within the cells. Okay? So تتدثر خلينا نحكي أو تتخبى داخل هاي الخلايا. That's why it's called. عرفت ليش متدثرة؟ كويس، بس يعني سألت بحماس أنت هيك. ليش المتدثرة؟ هيك هاي السبب. Okay. المتدثرة can infect several epithelium types. So in the urethra, cervix, endometrium, in the uterus, fallopian tubes, and also can infect the conjunctiva, importantly. And that is one important part in the transmission of chlamydia, as we see. But chlamydia has a unique life cycle compared to bacteria. So do you know of any other bacteria that has two forms, let's say two forms in its life cycle? That is quite uncommon in bacteria. Maybe there's spores, if you count that. But those forms are specific for chlamydia, that it has two forms. One is metabolically inactive infectious form called the elementary body. That's the form that can survive extracellularly and infect cells. After it goes inside, it switches into another form that is metabolically active, allows the cell to replicate and so on. And this is a non-infectious form called the reticulate body. So it goes inside with the elementary body, then starts to grow and replicate, and then it forms the reticulate bodies inside. Then the cell blows up, and some of the elementary bodies will go to infect other cells and other hosts and so on. Okay, and those characteristics we saw makes chlamydia a good pathogen, a successful pathogen in transmission. So it has very little symptoms. In many cases, the infection is asymptomatic and also has a specific form which can cause infection and survive extracellularly. If you remember with Trypanosoma pallidum, we said it cannot survive on inanimate objects. So you'll probably not get syphilis from using the toiletries of someone with syphilis. But in the case of chlamydia in the form of the reticulate bodies, or the elementary bodies, sorry, it can survive extracellularly. It can survive on inanimate objects, so on towels and so on. So if you use the towel of someone with chlamydia, then there is a chance that it can be transmitted. And the reservoir for chlamydia actually in endemic areas are the eyes of children, of small children. So we said it can infect the conjunctiva. That's one of the epithelium it can infect is the conjunctival epithelium. And then it can transmit from there through eye-to-eye transmission by droplets or hands or contaminated clothing, other than, of course, sexual transmission. And when it's in the eye, it can cause a disease, although it's not the subject here. It can cause a disease called trachoma. And trachoma is the leading cause of preventable blindness around the world. And it mostly happens where? In rural areas, where they cannot treat the infection early. They end up with this chronic disease that will lead to blindness, although it can be treated maybe with a single dose of antibiotics. But they go blind because they do not have access to proper health care. Right, so it can cause trachoma here, we said. And of course, what we care about are the urogenital infections and another infection caused by some serotypes of chlamydia called lymphogranuloma virineum. And it shows in the form of a painful ulcer, okay? Other than the painless ulcer or the chancre that we saw in syphilis. And in many women, again, like gonorrhea, it's asymptomatic, while in men, it's mostly symptomatic, right? And also it can ascend and cause pelvic inflammatory disease. And depending on where it infects, it can cause infection in the cervix, causing cervicitis or urethritis or proctitis if it's in the rectum. Okay? And again, we go back to exudates or discharge, and we look at those swabs. And also, urine can be helpful. So, other than the mid-catch urine, which we used in UTIs in order to decrease the contamination with bacteria found on the urethra or the tip of the urethra, here we use something called first catch. We are actually looking for the pathogen that are first pushed out by the urine, that are infecting the urethra. So first catch urine can be useful in finding those pathogens. And culture is not routinely recommended. Why? With chlamydia. Yes, because it's intracellular and might be expensive and difficult to grow, right? We need to grow mammalian cells and infect them with chlamydia in order for it to grow. And then we can do nucleic acid amplification tests, which are highly sensitive and became the diagnostic test of choice, as we saw for also gonorrhea. And treatment should include sexual partner, of course, and involves doxycycline and azithromycin. Now we have the urethritis caused is sometimes classified into gonococcal, caused by Neisseria gonorrhea, and non-gonococcal, caused by other pathogens. So chlamydia, if it causes urethritis, or even Trichomonas vaginalis, which causes urethritis, they can call it non-gonococcal urethritis. And many pathogens can cause this non-gonococcal urethritis. Some of them are the mycoplasma and ureaplasma, which are considered the smallest free-living bacteria. See how small they are compared to cells. And they lack a cell wall. They're different from gram-positive and gram-negative. They don't have the peptidoglycan and lipopolysaccharide you expect to find. They lack a cell wall altogether. And that's why you can find them with different shapes. They're not cocci, they're not bacilli. The lack of cell wall makes them come in many shapes. And they can cause, other than the urethritis, if they ascend upwards, of course, they can cause pelvic inflammatory disease. And to diagnose them, again, PCR amplification, nucleic acid amplification tests are quite important. And they are a problem recently because of their antimicrobial resistance, similar to what we're facing with chlamydia and gonorrhea. Okay. Finally, we come to a non-bacterial STD, which happens mostly in females. Very, very rarely it will be transmitted to the male partner. That is vulvovaginal candidiasis, where mostly it's Candida albicans causing an infection within the vagina. Now, Candida albicans is a normal part of the gut flora and also of the vaginal flora. That's why they consider it an opportunistic pathogen, because it is normally there, but sometimes it can overpopulate the vagina and cause this thrush with the appearance of this white exudate, or white plaques also. And you can do a swab from this, put it on a wet mount very quickly, and add potassium hydroxide, which will help in lysing the epithelial cells and so on, and you end up with the yeast and hyphae of the Candida albicans. And then you can tell that this is vulvovaginal candidiasis. And it mostly happens in premenopausal women, with around maybe 50% of women at least reporting one case of candidiasis. This is a picture that helps you remember vaginal thrush or vulvovaginal candidiasis. Now, in many cases, in many of the sporadic cases, there is a genetic susceptibility for recurrent infections. Okay, so some women are just unlucky in that they will keep getting those candidiasis episodes. And some of the risk factors for this candidiasis is diabetes, HIV, antibiotic use, which affects the vaginal flora, HIV with its immune suppression, and pregnancy also will cause some changes in vaginal ecology, and maybe that can predispose to vulvovaginal candidiasis. And the symptoms will probably involve pruritus, which means there's an itch, and maybe pain on urination. And when you examine, you see those white plaques. You do the test, the potassium hydroxide test, and you see the hyphae under the microscope. Then you can say with some certainty that it is vulvovaginal candidiasis. And then sometimes there's a discharge that looks like cottage cheese, which we have here. And then the pH also is still acidic. إذا بدنا نقارنها في trichomoniasis and bacterial vaginosis, in those cases the vaginal pH was increased, right? اللي هناك تعالوا هون لو سمحت. Okay. So this is the wet mount of the discharge, which allows you to see the hyphae and the yeast. And some women, commonly, because they keep having those recurrent infections, what they do is that they self-diagnose. Okay, so they say, okay, I have عندي هذول الفطريات, there's an itch, there's a discharge, and on their own they go and take antifungal drugs in order to treat the infection. But it seems that 34% of those women only are correct. Often self-diagnosis is unreliable. So what you do is you give either peroral or topical antifungal drugs, and if the patient does not respond to a short treatment course, then you should increase the course over to 2 weeks. Now, if the patient is pregnant, you do not give peroral antifungals because those are contraindicated in pregnancy. So instead, you give topical antifungal drugs. Okay? All good until now. We can now move on and see some clinical cases. ضل معنا وقت كويس. Let's start with this case report. All of those are from, or most of them, are from case reports in journals that has been peer reviewed and so on. And some of them I took from textbooks, yes. Yes, candidiasis. لا يعتبر STD ولكن sexual behavior can also play a part in getting vulvovaginal candidiasis. وبعدين ممكن يسموه STD ليش؟ لأنه حكينا it can be transmitted in very rare occasions to the sexual partner. So it can also infect the penis as well. So for that case, you can call it an STD. Yes? Now, let's start with the first case report of a 26-year-old male, okay, came to the dermatology clinic of Tanta University. This was in Egypt, في مصر, الدنيا. Complaining from severe burning sensation during urination and dysuria. Okay, so there is pain on urination. So far, from the previous lecture, we said a male coming with dysuria and pain on urination. We start thinking maybe prostatitis, right? That is on our list of differential. But then he's suffering from penile discharge and testicular tenderness. Then now we start thinking more STD. There's a discharge along with the dysuria. It's probably STD. And then if you ask about the sexual history, you find that there is multiple heterosexual relationships within the past 8 days. So a risk factor for an STD, multiple sexual partners. Normal blood pressure and pulse and temperature, but there is mucopurulent discharge from the urethra and swollen testicles when you examine him. And then when the patient was asked about any other symptoms, there is fatigue, pain, knee joints, ankles, all a bit foggy. And then he says redness in the eyes and edema in the eyelid, copious discharge, conjunctivitis. So an STD and also an infection in the eyes, conjunctivitis. Sorry? Could be chlamydia, could be gonorrhea. So far, sorry? Okay, we'll see. We continue. Following counseling, urethral and ocular swabs. So we take swabs, as we said. So discharge, we take swabs. Aseptically obtained, streaked on tire martin and chocolate agar plate. So we put on chocolate agar. If it grows there, diplococcii, gonorrhea, right? And doesn't grow on tire martin. It shouldn't grow here. It should grow only on the chocolate agar, right? Incubate overnight. they have grayish-white, transparent, raised colonies. Okay, colonies. You do gram staining on them, and you find pink to red diplococci, which means gram-negative diplococci. And this result, they say, was sufficient for presumptive identification. Right? We said microscopy and culture growing only on chocolate agar, presumptive identification of Neisseria gonorrhoeae. And also they see polymorphonuclear cells with the intracellular diplococci. Okay, so this is gonorrhea. What do they do after they grow the pathogen? They try and see what antibiotics it's susceptible to, and surprise, the person has multiple drug resistance with the pathogens. You can see this is the antibiotic disk susceptibility, and many of the antibiotics were found to be not effective against the pathogen, including ampicillin, cefotaxime, ceftriaxone. Yes?
It's not that serious,
Empirical treatment? No, you shouldn't. You shouldn't. The susceptibility test should not take too long. Okay? So if there's no systemic manifestations of the infection, you can wait maybe for a couple of days in order to get back the susceptibility tests. Okay? But maybe at the time you can check the guidelines for how you deal with the pathogen. Pathogens, resistance to many antimicrobials is updated regularly. Okay, so you can go to the guidelines and see if you're supposed to give empirical antibiotic treatment, and also you should be the judge of that case. In that case, if you see the person not in need of empirical antibiotic treatment, you can wait for the sensitivity testing. Okay, so what does this case tell us? When you get the discharge and the infection in the eyes, it can be many causes, but when you test it and see the diplococci and growth on chocolate agar, that's gonorrhea, and also tells us that it's a problem that we're facing antimicrobial resistance to gonorrhea. So we're having types of gonorrhea with multiple drug resistance, and that is a problem. Tamam? Now let's move on to another case of a 17-year-old white female college student seeking advice about contraception. She's shy talking about her sexual practices, and she never had a pelvic exam, but she has had 2 sex partners in the past 6 months without use of condoms. So this is, in some way, you can list it as a risk factor, right? No use of protection, multiple sexual partners, younger age, shy about talking about sexual practices. عفوا شخصت على السريع. Okay, so she denies vaginal discharge. يعني مش مبين أي شيء that tells us STD, right? No vaginal discharge, no dyspareunia, genital lesions or sores. She was only there to ask about contraception. But it seems that the clinician decided that since she has risk factors for the STD, and also maybe part of the counseling for giving contraceptives, you need to examine the genital tract. So upon physical examination, everything looks normal except for the cervix that appeared inflamed and bled easily, and there was a purulent discharge coming from the cervix. Okay, so even the patient herself was not coming from an STD. Physical examination, by chance, we find there is a discharge. So that tells us also that in many cases, STDs in women are asymptomatic. Okay, they'll be asymptomatic. So which laboratory test should be ordered or performed for this patient? For chlamydia, for gonorrhea, for syphilis, Do you do a wet mount and look for the Candida or Trichomonas? Or do you counsel and test for HIV? Anyone? Any idea? Chlamydia? Who has? So what do we know? We only find a urethral cervical discharge. That's all we have. I'm sorry? Yes, exactly. Actually, we order all of them. So we need to order all of those laboratory tests. Because also we said if we suspect one STD, we should examine other STDs as well, right? Including HIV, syphilis, Neisseria, chlamydia, and we do the wet mount to look for Candida albicans or Trichomonas or clue cells maybe. So indeed we order all of those tests. And if we look at her laboratory results, we find that the nucleic acid amplification tests are positive for chlamydia. She is negative for gonorrhea. And the RPR test, which is screening for what? RPR. And VDLR, screening for what? Syphilis. So those are negative. So not syphilis, not Neisseria, gonorrhea. We do a wet mount. We don't find clue cells which reflect bacterial vaginosis. We do not find Trichomona vaginalis swimming in the preparation. We don't find the protozoa, so it's not trichomoniasis. The KOH preparation is negative for the whiff test. You know what we did not call it whiff test in the previous lecture, but we said that if you add potassium hydroxide, you will get a certain distinct fishy smell. So that is the whiff test, that you whiff and you find this. In this case, it was negative. You do a test for HIV because we said with these other STDs, you can find there's an increased chance in finding other STDs. You do a pregnancy test and it's negative, so this is a case of chlamydia that was asymptomatic in this 17-year-old. Now let's see the other case. A 39-year-old man presented to the emergency department, several weeks of generalized weakness, headache, nausea, migratory arthralgias. So far, just constitutional symptoms. The patient had exclusively had sex with men, so he falls within the risk factor group of MSM, or men having sex with men, and participated in condomless anal insertive and receptive intercourse. So those sexual practices also put him in risk for certain diseases, and says he's been in a monogamous relationship for the past 6 months. Now, physical examination reveals a painful ulcerated plaque on the upper lip that we can see here. So ulceration here. And the macular rash with 3 crater-like scarred painless lesions that they consider to be healing chancres. So far, what do we think? Syphilis, yeah, because of the chancres on the lip or on the penis, and we said they heal on their own, right? The chancres, they heal on their own. Otherwise, we find, also we have hyperkeratotic maculopapular palmar rash on the palms, maculopapular, with the chancres. What is this? Syphilis, secondary syphilis, right? Secondary syphilis. There is the maculopapular rash. And then they look at gummas. There's no gummas, no neurological deficits, no cardiovascular abnormalities. Then it's not tertiary syphilis. It did not proceed to tertiary syphilis. They do some testing for HIV and even hepatitis B because of the sexual practice of what did they call it? Receptive and insertive anal intercourse, okay? Puts you at risk for HIV. So the patient was vaccinated or immunized for hepatitis B. So given the presentation and the diagnosis, okay, and he is positive for the RPR test, right? So giving this, what do we call it? Secondary syphilis, and how do you treat it? Penicillin G. It's quite simple. We do not have that big of a problem with resistance to antibiotics in the case of syphilis. Penicillin G. Good. Another case of this one is gonococcal arthritis. We already know it from the title here, gonococcal arthritis, but let's see the presentation. A 17-year-old girl, history of fever, chills, malaise, sore throat, skin rash, polyarthralgias. So she presents only with the constitutional symptoms, not with the symptoms of the genital tract. But she reports being sexually active and having a 5-week history of profuse vaginal discharge that was untreated. So maybe due to the stigma, maybe because it wasn't painful, she decided not to go to the clinic. And she lived with that discharge for around 5 weeks. And what do you think happened? Why does she have the constitutional symptoms? She has a disseminated infection. The infection went into the blood, and now she has a disseminated gonococcal infection. We said that Neisseria gonorrhoeae can go into the blood and cause a disseminated infection that can reach the joints and the skin, causing the rash, and the joints causing the arthralgias or rash, pain in joints that she was having. Cultures of her cervix were positive for Neisseria gonorrhoeae. And what do we culture Neisseria gonorrhoeae on? On chocolate agar. And the blood specimens, exudates, and synovial fluid were all sterile. So, for some reason, the blood specimen was sterile. Or maybe the way we cultured those samples, we were not able to retrieve the pathogen. Okay? So the diagnosis of disseminated gonorrhea with polyarthritis was made, and she was successfully treated with penicillin G for 2 weeks. And what does this illustrate? It illustrates the limitations of culture in disseminated infections. So maybe we will not be able to find the pathogen in the blood or in the joints, but having retrieved the pathogen at least from one place, from the cervix, for example, that is clinically significant. And it also shows the value of careful history, because if he did not ask her about the profuse yellowish discharge, then they would not have suspected maybe gonococcal arthritis.